Flexion and extension views are often referred to as hyperflexion and hyperextension views. They're used in both the C-spine and the L-spine for different reasons. Some for the same reason, but some for different reasons. In both the C-spine and the L-spine, they may be used to assess fusion after the patient's had surgery. And this is where a patient has a bulging disc that's so bad that it's pressing back on the spinal column. They completely remove the disc, but when they do so, you've got a gap in between two vertebrae. So they'll fuse those two vertebrae together, and it may be with a number of different things. They may take a bone plug, either from a cadaver or from the patient's body somewhere, and put it in and put plates and screws across what used to be the disc space, but now it's just an empty space. And so after a few days, or after a few weeks actually, what they want to see is whether or not that bone plug is starting to fuse to the vertebra so that it becomes one solid piece of bone. So what we do is we have the patient stand in a lateral position for the C-spine that would be at 72 inches, just like a lateral C-spine, and have them tuck their chin as far as they can towards their chest, and that would be flexion. And then you would take a second lateral. You'd take one with the chin tucked. That's your flexion view. And then have the patient relax and have the patient extend their chin as far as possible and look up as far as possible and take your extension view. It can also be used after a trauma situation, after the patient's cleared and they're off of the backboard and the doctor removes the C-collar. And it's especially used in children after a trauma situation to rule out what we call pseudosubluxation. And in children, the reason it's important is because in children, what we have is, because of the abnormally large or unusually large size of the skull compared to the rest of the body, C1 and C2 are overdeveloped in children. So you kind of got a hypertrophy type situation going on in children. And so in the children, what it looks like is you've got a slight subluxation between C2 and 3. C2 is abnormally large. It's not abnormally large for children, but compared to adults, it's abnormally large. So it looks like you've got a little bit of subluxation there. So we'll use the flexion extension views to rule that out in children, but also in children and adults as well. We'll use it post-trauma to assess the ligamentous attachment at the spinous processes. So it's very, very important that whenever you're doing flexion extension views, that the patient be allowed to flex and extend to their ability, and you don't force the patient into any kind of flexion or extension. So it's a hands-off type thing. Ask the patient to tuck their chin as far as possible, make an exposure, ask the patient to extend their chin as far as possible, make an exposure. So with kids, sometimes it's easier to say something like, I want you to see if you can look at your belly button. So they look down, and then ask them to look at the ceiling, and they'll look up. Sometimes your hospitals will ask for a 3-view flexion extension series, which would really be a lateral, just a regular Grandy method, and a flexion extension. So again, the textbook refers to that as hyperflexion, hyperextension, and that's just what it is. It's just flexion extension. Not real sure why we have to include the hyper in both of those, but it can also help to diagnose, again, not just the conditions we were talking about before with the pseudosubluxation in kids, but we can assess whether or not a fusion is taking, and also possibly if they're suspected of having some sort of ligamentous attachment issues, we can assess those as well. Central ray location is the same as for a lateral. That's to C4, and this would be your flexion, this would be your extension. If the top of T1 is not demonstrated, then again, we're going to have some issues if we need to see all the way down to C7 T1. So they may even have to shoot a swimmers with the patient flexion extension as well. So what we're looking for is evidence of proper collimation again. We want to see all 7 cervical vertebrae, and we want to see from the sella turcica all the way down to the top of T1. We want to, on the lateral, what we're going to see on the lateral in hyperflexion, hyperextension, or just the straight lateral, what we're going to see is the zygapophyseal joints open. The zygapophyseal joints on the lateral are going to look like this. This little line right here is your zygapophyseal joint. So remember on Monday I'd mentioned that we're going to see different things, different views on each portion of the spine. And lateral, that's what we're going to be looking at, is that zygapophyseal joint. So the zygapophyseal joint is just a line in between the superior articular process of one vertebra and the inferior articular process of the next adjacent vertebra. They're very easy to see on lateral C-spine. So different types of fractures that we might visualize on lateral C-spine would be the subluxation that I was talking about on a swimmer's, or on a hangman's fracture, would be where we've got separation between C2 and C3. So you're probably going to have a posterior arch fracture. You're going to have massive swelling of the prevertebral fat pad so that the airway is swollen far away from the vertebra itself. If we have a teardrop fracture, again, we're going to have that. It's going to be more subtle. We're not going to have the massive trauma to the posterior arch, but we'll still have that swelling away from the spine. So it's very important to be able to visualize that prevertebral fat pad. We can also evaluate the presence of whiplash, soft tissue injuries. What soft tissue injuries will do is take that bow, that lordotic curvature, out of the C-spine so that the C-spine is actually very straight. And in some cases, you'll actually see a slight kyphotic curvature in the C-spine because of soft tissue injuries. We can see loss of joint space or loss of disc space because of arthritis or age and wear and tear. We can see fusions or natural fusions. It's whenever a patient has severe arthritis, because of the stimulation at the articular surfaces, what will happen in a lot of cases is we'll get these bone spurs that reach inferiorly from one vertebra and superiorly from the other. And the patient will actually have what they call autofusion. The body creates a fusion between a couple of vertebrae. When we need to evaluate the patient for their intervertebral disc space and whether or not they've got some occlusion of the disc space, then we need to do obliques. So our obliques, we're still going to have an increase in OID, so we need to increase our SID in order to visualize it. Our obliques are going to be a 45-degree oblique, and you can do them either AP or PA. It doesn't really matter. In both cases, they're going to be a 45-degree oblique. There is going to be some difference in the angulation of the central ray, though. For an AP oblique, what we're going to do is oblique the patient as AP oblique, so they will be in an LPO and an RPO position. So it's always going to be both. You're not just going to do a unilateral oblique. When you're doing obliques of the spines, you're going to do both obliques. So if you're shooting AP, it's going to be an LPO position, AP projection, and an RPO position, AP projection. So the image receptor is going to be centered at C3. Central ray is going to be directed to C4, but the central ray is going to be angled cephalic 15 to 20 degrees. The 15 to 20 degrees is for the same reason we angle the central ray for the AP C-spine, and the difference between the 15 and 20 degrees is whether or not the patient is upright or laying down. But the reason for the angulation in this case is because what we're going to be looking for is the intervertebral foramina, and it comes off at a inferior angle. So the foramina, the hole in between the two, doesn't come off just straight from the side. It comes off at an angle. And it kind of makes sense, and it's a little bit of common sense. If those spinal nerves are coming out of the vertebra and they're going into the upper extremity, then they don't need to come straight out laterally and then take a 90-degree turn to get into the extremities. They're going to come off at a 15, 20-degree angle. So again, we're going to center our image receptor at C3. Our central ray is going to be directed to C4, and by the time our central ray gets to our image receptor, we have to have the image receptor a little bit higher than where we're going to put our central ray. So the angulation on the central ray projects the anatomy cephalad to the higher elevation at the image receptor. We want the chin elevated so that the AML is parallel to the floor when the patient's upright. So chin elevated and protruded, and the AML should be parallel to the floor when the patient's upright, perpendicular to the floor when the patient's laying down. So the central ray, again, is going to be directed to C4 at 15 to 20 degrees cephalic angulation. So it looks like this. And some of your textbooks have you turn the patient's head into a true lateral position. And some of your textbooks tell you to just have the patient look straight forward from the position that they're in. Not looking towards the x-ray tube, but they're at a 45-degree oblique, so don't move the head. The head should be at a 45-degree oblique as well. It looks like they've got this patient with their head tilted a little bit, and I don't really recommend that you do that. Just have the patient stand with their AML parallel to the floor, looking straight ahead from their body position. So what we're going to see is evidence of proper collimation. Of course, the length of your collimated field should be 12 inches, but you don't necessarily have to have the full 10-inch laterally. You just want to make sure that you don't over-collimate down to the skin level. You should see all 7 cervical vertebrae in the first thoracic vertebra. Not imperative to see the sella turcica on this one. Your image receptor is still going to be about the same level, but you're not going to see the sella turcica well. It's going to be rotated. So 45-degree oblique, and what you should see is the open intervertebral foramina furthest from the image receptor. So you have 2. You have one that comes off of it's kind of the anterior-lateral side on the left-hand side, and then one on the right-hand side as well. So as you oblique the patient, you angle 15 to 20 degrees cephalically, what you're going to be doing is shooting your central ray straight up through that intervertebral foramina to see it open. And what you're going to see on the AP is the side that's furthest away from the image receptor. And so what it should look like is this right here. You're looking at that hole right there. Some of your hospitals will use what they call trauma obliques on trauma patients to further assess where the lateral may not show you exactly what you want to see, especially in the lower portion of the C-spine. So with a trauma oblique, what we're going to do, obviously they're going to be AP obliques. And what we're going to do, the patient's still on a backboard, patient's still on a collar, patient's not cleared. So what we're going to have to do is not move the patient, but rather use the central ray to give us what it is that we should see with patient positioning and central ray positioning. In other words, what we're going to have to do is angle our central ray in 2 planes. We're going to have to accomplish the positioning with the positioning of the central ray. So it's going to utilize a 45-degree medial angulation plus a 15 to 20 degree cephalic angulation. So with the patient laying down, it'd be a 15-degree cephalic angulation. The tricky thing here is that because of the steep angulation, especially from lateral to medial, your image receptor placement is going to have to be offset a little bit in order to put the anatomy in the center of the image receptor. That's number one. And number two is that you can't do this in the table because you're going to be angling with the central ray in two different directions. And one of those directions is going to be against the grid strips. So you can't even use a tabletop grid. You've got to shoot this tabletop without a grid. And so you're going to have some scatter radiation that is going to cloud up the image a little bit. But what we see in that is, going back to our lateral C-spine, one thing that sometimes can be inconclusive on a lateral, you can see that something's not right, but you can't make a definitive diagnosis, is that if we have what we call a locked facet, let's say the patient was in a rollover accident, and one of these zygapophyseal joints, we have a twisting injury to the C-spine. One of these zygapophyseal joints, maybe the side closest to the image receptor, slips forward so that we've got this side, the side elevated. We can see very, very well the zygapophyseal joint. But if something just looks funny at this level, what we may have is a situation where we don't have a full subluxation, but we do have one of the zygapophyseal joints, the superior articular process, is slipped anterior to the inferior articular process. And that's what we call a locked facet. If we don't see it on the lateral, or if something looks kind of weird, but we can't really make out what it is, then the trauma oblique helps us to identify that. So the patient's technically got a broken neck with a locked facet, even though there's no broken bones and it's stable, and the patient probably is not feeling, they may have some tingling, some pretty severe tingling and weakness, but they may not have suffered any paralysis. So if they can get that patient to the ER or to the OR and put some traction on the neck, probably with some pins into the skull that kind of like a halo, but the patient isn't wearing a halo that would attach to their body. What it would be is a halo apparatus that's holding onto the head, and they may hang some weights off the head of the bed in order to provide some traction to hopefully bring that back into position. So trauma obliques are very useful in order to diagnose those things. And what we're going to see in the trauma obliques is that the facet or the articular processes are visualized on the posterior side instead of having their normal appearance, and this really isn't a normal appearance. What we can see is the one articular process in front of the other. In a PA axial, we're going to see the side closest to the image receptor. So since those articular processes are coming off from medial to lateral at an oblique angulation, plus from superior to inferior at an angulation as well. For our PA obliques, we're going to shoot with a 15 to 20 degree caudal angulation. And realistically, since we're not going to likely do any PA obliques with a patient on the table, your degree of angulation for your PA obliques are going to be 20 degrees, just because the patient's going to be upright. Now, it doesn't look like the patient's got their head tilted in this one, so the positioning's a whole lot better. I'd say 95 out of 100 techs are going to shoot their obliques with patient AP. So if they're upright, they're going to be AP. If they're on the table, obviously they're going to be prone. So if you happen to be the oddball in the department and you shoot your obliques PA, you need to mark your images. You need to mark, document somewhere in the system that shows that you shot them PA. Otherwise, your images are going to look like your LPO is really your RPO. Your RPO is really a LPO. Because you shot them PA, everything's going to look backwards. So your PA obliques, two things about those. 45 degrees still, and now your central ray angulation is going to be caudal. Everything else really is, you're going to be evaluating the same information. Your central ray being caudal, your image receptor is now going to be at C5 because of the angulation of the central ray. Your central ray is going to be directed to C4 at 20-degree caudal angulation. But you're going to see all the same stuff. You're going to see all the way down to C2, from C2, C3, all the way down to C7, T1. And that's really a better look at what your AP or your PA obliques are supposed to show. If you can see your articular processes here, even though that's not really what you're supposed to be looking at on your obliques, what you're supposed to be looking at is the intervertebral foramina. For the PA now, it's going to be on the downside. For the AP, it's going to be on the upside. But I point out the articular processes because of what we were talking about before for the trauma obliques. This is more like what they're supposed to show. I'll see if I can make this larger. Okay, so the anatomy that we're looking at obviously is, again, the open intervertebral foramina. But on the trauma obliques, what we're looking for is you should be able to visualize this bright thing right here and this bright thing right there. So this is exactly how it's supposed to appear, is that the top of the upper articular process should be over, I'm sorry, the bottom of this upper articular process should be over the top of the articular process below it. So that's really your zygohypophyseal joint there. You don't see it as distinct a line as what you see on the lateral because you're not looking for that for the oblique. You're looking at the open intervertebral foramina. However, on those trauma obliques, what you're going to see if you've got a unilateral lock facet is that is going to be anterior instead of posterior. So the articular surface of the superior vertebra is going to be anterior instead of posterior to the superior articular process of the vertebra below. I think it's important to point out the different types of series that you may see for the C-spine because we've got a lot of them. All right, so for a two-view C-spine, you're always going to have an AP axial. That's going to demonstrate from C3 down. Remember, even if it just calls for a two-view, which would seem to be an AP and a lateral, you're always going to include an open mouth odontoid. So your two-view is generally at minimum three-view, AP, lateral, open mouth odontoid. So the purpose for the open mouth odontoid is to demonstrate C1 and C2. So the open mouth odontoid completes the AP. So there's really no such thing as two-view unless it's a flexion extension, and then your request for flexion extension should reflect that. If you shoot your AP open mouth odontoid and your lateral and you don't see the top of T1 on the lateral, then you have to take it upon yourself to complete a swimmer's. The swimmer's completes the lateral. So you don't have to go ask somebody, if you don't see the top of T1, you don't need to go ask the radiologist whether or not you need to shoot a swimmer's. You're the imaging expert. So if you don't see the top of T1, then naturally you just go ahead and shoot a swimmer's. So really your two-view is somewhere between 3 and 5 views. It's always an AP, a lateral, and an open mouth odontoid. It might include a swimmer's. It might include a Fuchs. So, if you don't get the very tip of the odontoid process, and your doctor wants it, then you may need to shoot the Fuchs. So apiaxial, open mouth odontoid, Fuchs if the dens is not entirely demonstrated, lateral, and swimmers if the top of T1 isn't demonstrated. So a C-spine series or a complete series is the same as a two view, but we also include the two obliques. So really it's somewhere in between 5 views and 7 views. So it may be AP, lateral, open mouth odontoid, and both obliques, which makes it a 5 view. Or if you don't get the tip of the odontoid, it may be a 6 view. If you don't get the tip of the odontoid or the top of T7, or I'm sorry, top of T1, then it's going to be a 7 view. So flexion extension are not normal views that are included in the C-spine series. Those are kind of specialty views. So it's a view or a couple of views that are included just for specific reasons. So again, your common C-spine fractures, you've got a odontoid fracture. We talked about that. It's usually at the base, but it can be at the upper portion of the odontoid. They usually fix that with a screw. Atlantoaxial subluxation is where you have that tear of that ligament that should hold the odontoid process into the anterior portion of the ring of the atlas. You got Jefferson fracture, and Jefferson fracture is that axial loading fracture that we talked about, and we diagnose the odontoid fracture and Jefferson fracture with the open mouth odontoid. The atlantoaxial subluxation is where we can diagnose that on the lateral. Hangman's fracture, it's a fracture subluxation at C2 and C3, and we can diagnose that on lateral. Teardrop fracture is a small fracture off the bottom portion of a vertebra, and we can diagnose that on the lateral. Clay shoveler's fracture we didn't really talk about, but it's kind of like a stress fracture, and it's not an insignificant fracture, but it's not an unstable fracture. What we have with a clay shoveler's fracture, this is your vertebral prominence back here. 1, 2, 3, 4, 5, 6, 7. No, that is it. Okay, so that's your 7th cervical vertebra. And what happens with a clay shoveler's fracture is because of a lot of stress on the upper body, sometimes you can fracture the spinous process of C7 of your vertebral prominence. And it was first identified with people who, before we had backhoes and things like that, used shovels to do a lot of shoveling. And if you've lived in East Texas for any amount of time, you know you'll walk across a field that's made out of clay and you pick up a lot of clay on the bottom of your shoes. And in clay shovelers, the same thing applied to the shoveling of clay. You scoop up some clay and you try to throw it off of your shovel, and it just doesn't come off very easily. And that stress can cause a stress fracture of the vertebral prominence. So that's what we call a clay shoveler's fracture. Very uncomfortable for the patient, but it's not an unstable fracture where the patient's going to suffer from paralysis. Back to where we were. And then whiplash is not really a fracture, that's soft tissue injury, and we can diagnose that on the lateral of the C-spine. So here we've got an actual odontoid fracture, and it's fractured down into the body of C2. So this fracture is never going to be demonstrated on the Fuchs, and for whatever reason I've got open mouth odontoid on there. So it's very important, vitally important to get a good open mouth odontoid, because that's never going to be demonstrated on the Fuchs. If they didn't get that here, then they could have sent this patient home with a broken neck. So atlanto-occipital dislocation, usually caused by a transverse ligament fracture. And what we've got is a misalignment. You can see the odontoid process. This is C2. And that, I'll magnify this up. That is your odontoid process, and it should be right there, but it's further back in the vertebral foramina C1. We've also got a little bit of a tilt. This is exactly why it is that sometimes we'll shoot flexion and extension views, not necessarily for this particular fracture, but looking at the way we've got separation between the spinous processes of C2 and C3 is what we will see if the patient has some sort of ligamentous damage in the posterior, in between the spinous processes. As they flex, instead of having our spinous processes fan out evenly, you have a massive gap in between a couple of them, and that would be your indication that you got some sort of serious ligamentous damage there. A Jefferson fracture is also diagnosed on an open mouth odontoid, and what you get there is a difference between your lateral masses. So your lateral masses of C1 should line up with your lateral masses of C2. What we see is lateral mass of C2 on both sides is extended out past the lateral mass of C1. What happens with a Jefferson fracture is because of the multiple fractures in the ring type bone is the whole thing spreads out a little bit. So you get expansion of that ring, which indicates that you've got some sort of fracture going on there. So there's your Hangman's fracture. And believe it or not, this is not a severe Hangman's fracture, even though you've got subluxation here and you've got an obvious fracture of the posterior arch of C2. Sometimes these fractures and the separation between C2 and C3 is very, very significant. Also, believe it or not, this is a survivable fracture, providing it's not an extreme separation between the two. If that separation becomes too great, what happens is you get the brainstem that actually extends down into C1, into the vertebral foramina C1. And what happens is that with acute flexion at this level, you get involvement of the brainstem, and the patient dies immediately. But if you don't have that, then the patient can survive. They may be quadriplegic, or if it's not, if we don't really have any kind of subluxation at all and we've still got a clinical fracture, then the patient might not even suffer from any paralysis. And a teardrop fracture is what we have here. We have a teardrop fracture here, so we got a small fracture there, and then we've got the distance in between the spinous processes back here is very significant. This is a highly unstable fracture, and that is because we've lost that syndesmosis. And if we pop the collar off of this patient, even if they're not paralyzed before, we take the collar off this patient and have the patient move around. Any kind of movement could involve spinal cord injury and paralysis. Clay shoveler's fracture, really not a dangerous fracture. It's just very uncomfortable for the patient. And then finally, we have whiplash. We should have a lordotic curvature. With whiplash, what we have is a loss of that curvature, and the spine is straight. So that's the end of C-spine, but now we'll talk about T-spine and L-spine. And we're not going to do a whole lot on T-spine, but we'll spend a little bit more time on L-spine, sacrum, and coccyx. So your thoracic vertebra, you have 12. And again, they're in the posterior portion of the thoracic cavity. The unique features of the thoracic vertebra is that they have the costal facets. They look a lot like a hybrid between C-spine and L-spine, especially the upper portion of the thoracic, the upper thoracic vertebra look a lot like C-spine vertebra. but they have those costal facets. The lower portion look a lot like L-spine vertebra, but again, they've got the costal facets. So you've got facets on two different places. You've got facets for attachment of the ribs on the transverse process and also on the body. So again, on a drawing, if you see this little round density here and another one there, that indicates you're looking at a T-spine vertebra, regardless of what the appearance of the vertebra is. Lumbar vertebra, you have 5 in number, and they're in the posterior abdominal region. And the unique features there is really that you don't have transverse foramen and you don't have costal facets. But the transverse process are smaller than the T-spine, and then the pars interarticularis is a part of the lamina between the articular processes that we can see on the obliques. So the vertebra looks like that. Again, you look at the transverse process, you see nothing. You look at the transverse process on the lateral view, and you don't see any holes on the superior to inferior view. And on the lateral view, you don't see the articular facets for the ribs. And it indicates you've got a lumbar vertebra. The sacrum is formed from 5 individual vertebrae, 5 sacral segments that curve into one big triangular shaped bone. So it's wedged between the iliac bones of the pelvis and those articulations. We talked about that before as being your sacroiliac joints. So because it's joint space between the sacrum and the iliac bones of the pelvis. So your prominent features there are that you've got a promontory, a canal, a foramina, and a cornu. So they're formed by the fusion the coccyx is formed by a fusion of 3 to 5 vertebrae. Now, they don't really look like individual vertebrae. It's kind of looking at the pinky toe and trying to count out the number of phalanx you have in the 5th toe. They're really hard to separate. So it just really truly looks like a single bone. The coccyx does. So sacrum and coccyx here on the AP, you've got the sacral foramina. The lateral, it's just got this this curvature, kind of looks like a shrimp. So patient preparation, just remove your artifacts, general patient body, patient position. Most of the time it's going to be with the patient laying down. Sometimes if you're doing weight bearing or you just don't want to put the patient on the table, you can shoot them upright. T-spine, especially if you've got a patient who is kyphotic, if they've got an exaggerated kyphotic curvature like your older patients, then you might want to shoot them upright instead of putting them on the table. It's very uncomfortable for a patient who's got a very prominent kyphotic curvature to lay on the x-ray table. SID is going to be 40 inches. Use your markers, radiation protection, just use it where appropriate, and then patient instructions for the most part, depending on what you're shooting. If it's T-spine, we're going to have some specific instructions, but if it's L-spine, it's just going to be hold your breath. Same thing with sacrum and coccyx. Just hold your breath. So artifacts have to come off, necklaces, all that kind of stuff. It's really best to go ahead and put the patient in a gown. If you're doing an L-spine, you're going to have the patient lower the pants. If you're doing a T-spine, because of the bra, if you're doing a T-spine on a woman, or anything that may be in a man's pockets, or if the patient has prominent buttons or snaps on their shirt, it's going to have to come off anyway. So really best to just go ahead and put the patient in a gown. Image receptor size or collimated field size is going to be dependent on the exam that we're shooting. AP and lateral of the T-spine and L-spine typically is going to be on a 17 by 7. the field size will be a 7 by 17. But if we're taking x-rays of the sacrum and coccyx, it's usually a 10 by 12. Collimation being our most common radiation protection for all of these particular exams. We'll talk about breathing instructions on individual exams. So essential projections of the T-spine, L-spine, SI joints, sacrum and coccyx is what we're going to be. So T-spines, your essential projections are AP and lateral. Some hospitals will shoot obliques of the T-spines. We'll talk about those, but we're not going to spend a tremendous amount of time on them. For the most part, T-spines are going to be AP and lateral. So AP T-spine is going to be, the patient position is going to be very similar to a chest x-ray. We're not going to need to take your T-spine views at 72 inches though. Just 40 inches is fine. Patient supine or upright, depending on their comfort level. Shoulders in the same horizontal plane. Put their arms down to their side for the AP. If possible, orient the patient so that the lower thorax is at the cathode end of the x-ray tube. And the reason for that is because the intensity difference between the cathode and the anode end of the x-ray tube is different. So for reasons that we'll talk about in physics, and Trina, if she hasn't already, she will talk about them in imaging. We've got intensity differences between the two ends of the x-ray tube because of the equipment orientation and the anode as it relates to the stream of electrons across the tube and the emission from the x-ray tube itself. The anode itself provides greater filtration at the anode end of the x-ray tube that is not evident on the cathode end of the x-ray tube. So the cathode end of the x-ray tube, we've got an increase in intensity compared to the anode end of the tube. So cathode end of the x-ray tube, we've got more intensity. Anode end of the x-ray tube, we've got less intensity. The upper portion of the T-spine is thinner than the lower portion of the T-spine. So we want to put that thin end under the anode where the intensity is less. Put the thick end under the cathode where the intensity is greater. So that it evens out the intensity as it strikes the image receptor, so you get a more even appearance to the anatomy on the image receptor. It's what we call the anode heel effect. The heel of the anode causes an intensity difference between the cathode and the anode end of the x-ray tube. So positioning for the T-spine is going to be very similar to the chest x-ray. The top of the image receptor should be 1.5 inches, 2 inches above the outer portion of the shoulders. And that should put the center of the image receptor and the center of your central ray somewhere around T7. So your central ray should be perpendicular to the center of the image receptor. And it should enter about halfway between the jugular notch and the xiphoid process. Remember, your jugular notch is where the upper portion of your sternum ends. The xiphoid process is the most inferior portion of your sternum. So really, pretty much right in the middle of your sternum. So what we're going to be looking for is evidence of proper collimation. We want to see all 12 thoracic vertebrae. No rotation is demonstrated by the spinous processes in the midline of the vertebra. Vertebral column aligned to the middle of the radiograph, and we should be able to see the bony trabecular patterns. On your T-spine, you want to shoot on expiration. So have the patient take in a big deep breath and blow it all the way out, and shoot after they tell them to hold their breath after they blow it all the way out, and shoot afterwards. And what that does is it takes the lung and it compresses the lung and puts it all in the upper portion of the thoracic cavity. So you don't have much air in the lung. That increases the patient thickness, or not really thickness, but density on the upper portion of the T-spine. And it makes it more similar to the lower portion of the T-spine. So inhalation, blow it all the way out, shoot at the end of exhalation. So we should be able to see from T12 and we can CT 12 because that's where the ribs end, and then count up from there. So we got 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So we got 12 vertebrae. Your lateral, again, can be recumbent or with patient standing upright. The left lateral minimizes the heart magnification, but we're really not looking for heart magnification. So, if the best you can get is a right lateral, then that's going to be fine. So what we're going to do is align the long axis of the vertebral column horizontally. Make sure that you put a support under the patient's head. If the patient's laying down, flex their hips and put them out, their knees out in front of the patient for stability, but also for comfort. You're going to superimpose the hips and the knees to make sure the patient's in a good lateral position, and get the arms out of the way as well. So put the arms out in front of the patient. Just have them lay down kind of like they're going to go take a nap. Your central ray should be directed to the image receptor at T7 if the spine is horizontal. So it should be perpendicular to the image receptor if the spine is horizontal. What that's going to require is you to expose the patient's back and look at their spine. And, sometimes you have a patient that really doesn't have any curvatures, especially men who, again, like a buffet. And in some cases, their hips and their shoulders are about the same width, and you can look at their spine, and their gut, causes everything to be really kind of at the same level. So if you look at their spine and their spine is horizontal and parallel to the floor, to the image receptor, and to the table, then you just shoot perpendicular to the image receptor. If it's not, then you're going to have to do one of two things. Either use some sponges to build up under maybe the patient's waist to put the spine parallel to the image receptor. And if you don't do that, then what you need to do is angle your central ray 10 to 15 degrees cephalic. All right, so again, we got a range of angulation there, 10 to 15 degrees. Why is there a range? Well, on average, if you have a male, and men have a tendency to have broader shoulders and more narrow hips, then your angulation is going to have to be 15 degrees cephalic angulation. If you've got a female, then your angulation is only going to have to be about 10 because their shoulders tend to be not as broad. So your central ray is going to enter at T7. Your collimated field, or the center of your collimated field, should come pretty much straight down from the axilla. So find their axilla, their armpit, essentially, and your central ray should come straight down from that. And you should be able to collimate in. You shouldn't have to leave a wide open collimation. You should be able to collimate in some. But because of the thickness of the L spine, and we see this again in the T spine, we see it again in the L spine. Because of that thickness and all the soft tissue that you're going to be shooting through, you're going to create a lot of scatter radiation. So you can clean up the image a little bit, even with the collimation. You can clean up the image a little bit by taking a lead apron or some sort of other radiopaque thing and put behind the patient in order to clean up some of that scatter radiation before it strikes the image receptor. So both the L spine and the T spine have you a lead apron that you lay on the table behind the patient. Even though you collimate in, that will help the image to appear better anyway. So on your lateral T-spine, you should see evidence of proper collimation. You should see evidence of a lead blocker behind the patient. The vertebra should clearly be seen through the ribs, and you should see 12 thoracic vertebrae centered at the image receptor. Superimposition of the shoulder on the upper portion, but notice that you're not going to see T1 through T3. Just like on a chest x-ray, and probably even worse because the arms aren't going to be elevated, you're not going to see the upper portion. So what you're going to have to do is for a lateral T-spine. Whenever you're doing a lateral T-spine, you're going to do your AP and your lateral. And even if your series calls for a 2-view T-spine, it's always going to be a 3-view. So the swimmers on a C-spine series completes the lateral for the swimmers. On a T-spine series, on a C-spine series, you only shoot the swimmers when you can't see the top of T1. On a T-spine series, even if it calls for a 3-view or 2-view, you're always going to include a swimmers for a T-spine series. The lateral doesn't show you T1 through T3 or even C7. So on a lateral T-spine, you're just not going to see it. You're going to have to include a swimmers. Always include a swimmers for a T-spine series. On a T-spine, on a lateral T-spine, we're going to use motion to help us to improve the image. In almost every case, we want to eliminate motion so that we can get a sharper image. But on a lateral T-spine, we've got an image that is not a very good image, and we want to improve that by moving unwanted anatomy. So what we're going to do is a breathing technique. So with a breathing technique, what we're going to do is we're going to have to set a technique. You're probably not going to be able to phototime this, so you're going to have to learn techniques for lateral T-spine. And what you're going to do is you're going to use an adequate mass, but you're going to lower your MA station. So if you normally would use a 300 MA station, what you may have to do is drop it back to a 100 MA station. So for a lateral T-spine, you may have to use maybe 80 mass. So what that's going to require you to do is drop your MA as low as you can and extend your time as far as you can. If as low as you can get is 100 MA station, then what you may have to do is use 100 MA station at almost a 1-second exposure. Better still, if you can get a lower MA station, get as far out as a 3-second exposure, you can get a much better image. So the law of reciprocity is it's a law we apply to manipulation of mass so that we can use the same mass value by manipulating MA and time individually. So to get to 100 mass, let's say, if we have 100 mass, I can shoot with 100 MA at 1 second, so mass is calculated as MA times time. So 100 MA at 1 second gives me 100 mass. But 50 MA at 2 seconds, that would be 50 times 2, also gives me 100 mass. So reciprocity is give and take. You give one thing, you take another thing. So we can arrive at the same mass value by using shorter time and a higher MA station, or with using longer time and a lower MA station. So that's the law of reciprocity. And for breathing technique, what we want to use is, if at all possible, we want to use about 3-second exposure time, so that what we get is the appearance of the vertebra without the lung markings, the prominence of the lung markings. So what looks all fuzzy out here are the lung markings, and they're breathing through, or they're moving throughout the exposure. So common T-spine fractures, lower portion of T-spine, what we've got is a fracture and dislocation of the transverse process. The rib is broken apart. More commonly, what we see is compression fractures. So in a compression fracture, what we get is the appearance of the bone, instead of being box in shape, is kind of a wedge shape. And I touched on that on Monday. I talked about compression fractures in older patients who have osteoporosis. And it's very common, especially in women who are undergoing osteoporosis. They'll have multiple compression fractures that increases that kyphotic curvature, and the patient suddenly looks like they're slumping all the time. And all it is multiple compression fractures. So L-spine project, oh, let me back up just real quickly. Even though it's not in the PowerPoint, obliques are required in some hospitals as well. So obliques of the T-spine are um, very steep obliques. Um, our, our spine slowly changes its orientation, all right? And what I mean by that is the C-spine, on the C-spine, we see the zygapophyseal joints on the lateral. Again, zygapophyseal joints, that thing right there. So zygapophyseal joints we see on the lateral. On the oblique, we see the intervertebral foramina. That was not oblique. We see the intervertebral foramina. So that's 45 degrees. On the lateral of the T-spine, what we see is the intervertebral foramina. Right here, it's the intervertebral foramina. And you start to see the zygapophyseal joints. You need to oblique the patient either towards or away from the image receptor in order to truly visualize the zygapophyseal joints. So your degree of obliquity for a lateral T-spine is not quite lateral, right? So your lateral is where you see zygapophyseal joints on the C-spine. On the T-spine, it's almost lateral. So our obliquity is going to be about 70 degrees for the oblique of the T-spines. So if you're working in a hospital where you have to routinely shoot obliques of the T-spines, your obliquity is going to be about 70 degrees, so almost lateral. And what we see on that oblique, again, is the zygapophyseal joint. We see the open intervertebral foramina on the lateral. So since we see the foramina on the lateral, that means we're going to see the zygapophyseal joint on the oblique. Just like in the C-spine, we're going to see the anatomy of interest on the oblique on the upside if we shoot AP. So the zygapophyseal joint, that's going to be different. We saw the foramina on the C-spine. On the T-spine, we're going to see the zygapophyseal joint, but we're still going to see it on the elevated side with the patient AP. So it's going to be on the elevated side with the patient AP. We're going to see the upside on the AP, and if we shoot PA for the T-spine, for the oblique of the T-spine, we're going to see the downside.